Good morning. Today's lecture class is on study models and model analysis. So, as we all know, study models is an important aspect of orthodontics. The study model, the diagnostic aids is classified into essential diagnostic aids and supplemental diagnostic aids. So, essential diagnostic aids are essential in every case. So, they can be divided into case history, clinical examination, study models, certain radiographs like periapical radiographs, wide-beam radiographs, and panoramic radiographs, and also for facial photographs. The supplemental diagnostic aids can be specialized radiographs like OPG, lateral ceph, and PA view. Then electromyography, hand wrist radiographs, endocrine tests, basal metabolic rate estimation, and occlusograms. Now, what are these study models? So, orthodontic study models, they are essential diagnostic records which are accurate plaster reproductions of the teeth and their supporting soft tissues, and which helps to study the occlusion and dentition from all the three dimensions. Now, coming to the uses of study models. The first one is to assess and record the dental anatomy, to assess and record the intercuspation, to assess and record the arch form, to carry out various space analysis, to assess and record the curves of occlusion, to evaluate the occlusion with the aid of articulators, to measure the progress during treatment, to detect the abnormalities like localized enlargement and distortion of the arch forms, and also to provide a record before and immediately after and also several years following treatment for the purpose of studying treatment procedures. Now coming to the parts of a study model, the study model is divided into two portions, that is the anatomic portion and the artistic portion. So the anatomic portion, it is the impression of the dental arch and the supporting structures. And the artistic portion, it supports or orients the anatomic portion. So in a well-fabricated set of study models, the ratio of the anatomic portion to the artistic portion should be 3:1. Now coming to the model analysis. There is permanent dentition analysis and mixed dentition analysis. Under this permanent dentition analysis, we have the Pons analysis, Linderhardt analysis, Korkoff's analysis, Carey's analysis, Ashley-Hope's analysis, and the Bolton's analysis. Under mixed dentition analysis, we have Moyer's analysis, Tanaka and Johnson analysis, Hakaba analysis, and Hickson and Oldfather. Now, what is this Carey's analysis? This analysis is a permanent dentition analysis which is performed on the mandibular arch. Here, we have to determine the arch length by using a brass wire. So, this brass wire is placed from the mesial aspect of the first permanent molar to the along the buccal cusps, along the incisal edges to the mesial aspect of the opposite permanent molar. Okay, then determination of the total tooth material. This is done by with the help of a divider. Okay, the mesidistal width of the teeth spanning from the second premolar of one side to the other side is taken. Okay, now and this is summed up. Now determination of the discrepancy. So the difference between the arch length and the total tooth material is taken. Okay, and the inference is if the difference is coming between 0 to 2.5 mm, then a less tooth material is there, so proximal stripping can be done. 2.5 to 5 mm excess is there, then extraction of the second premolar is considered. And if there is a tooth material deficient, there's more than 5 mm, extraction of the first premolar is considered. Okay, the same. Okay. The next analysis, coming to the next analysis, there is a Ashley-Hope's analysis. So Ashley-Hope, he devised the formula to determine whether the apical basis could accommodate the patient's teeth. He considered tooth crowding to be deficiency in the arch width rather than the arch length. So in this, we have to determine the total tooth material, the premolar diameter, and the premolar basal arch width, and also the basal arch width. Okay, so if the premolar basal arch width is greater than the premolar diameter, then arch expansion is possible. And Hoves believes that if the PMBAW is equal approximately 44% of the total tooth material, if it is sufficiently large to accommodate all the teeth. Now, when the ratio between the PMBAW and the total tooth material is less than 37%, then the basal arch deficiency necessitating extraction of premolars. However, this analysis is useful in planning treatment of problems with suspected apical base deficiencies and deciding whether to extract the teeth, whether to widen the arch, or whether to expand the palate. Coming to the next analysis, that is a Pons analysis. So in 1909, Pons devised a method of predetermining an ideal arch width based on the mesodistal width of the crowns of the maxillary incisors. So he suggested that the ratio of the combined incisor width to the transverse arch width was ideally 0.8 in the bicuspid area and 0.64 in the first molar area. Here, the sum of the mesodistal width of the incisors are taken and the measured premolar value and the measured molar value is taken. So the expected arch width at the premolar region can be calculated using the formula sum of the incisors divided by 80 into 100. And the expected arch width at the molar region can be calculated using the formula sum of the incisors divided by 64 into 100. So, Pons suggested that the maxillary arch should expand 1 to 2 mm more than the treatment than his value to allow for relapse. And this, the amount of expansion that can be done on the molar and premolar region is estimated. What are the drawbacks of Pons analysis? So the researchers of the University of Washington found very poor correlation between the combined mesodistal incisor widths and the ultimate arch width in the bicuspid and molar areas. So he does not take the skeletal malrelation into consideration. So analysis is derived solely from the casts of French population, so it can't be applied globally. So the next analysis is the Linderhart's index. So this is similar to Pons analysis, but the variation in the formula to determine the expected arch width at the molar and the premolar regions. So the expected arch width at the premolar region can be calculated using the formula sum of the incisors divided by 85 into 100. Whereas the expected arch width at the molar region can be calculated using the formula sum of the incisors divided by 64 into 100. So the next analysis is the Korkhoff's analysis. So Korkhoff's analysis makes use of Linderhart formula to determine the ideal arch width in the premolar and the molar region. So a measurement is made from the midpoint of the interpremolar line to a point between the two maxillary incisors. So according to Korkhoff's, for a specific width of the upper incisors, a specific value of distance between the midpoint of the interpremolar line to the point between the two maxillary incisors should exist. So if there is an increase in this measurement, this will indicate the proclined upper incisors, whereas a decrease in this value indicates a retroclined upper incisors. Coming to the next analysis, that is a Bolton's tooth ratio analysis. So Bolton, he studied an interarch effect of discrepancies in the tooth size to devise a procedure for determining the ratio of the total mandibular versus maxillary tooth size and anterior mandibular versus maxillary tooth size. This study of these ratio helps in estimating the overjet and the overbite relationship that will likely obtain after the treatment is finished and estimating the effects of the contemplated extractions on posterior occlusion and incisor relationships, and also the identification of the occlusal misfit produced by the interarch tooth size incompatibilities. So how this procedure is carried out? Here, the sum of the mandibular 12 teeth are taken anterior to the first permanent molar, okay, and this is summed up. The second is sum of the maxillary. So sum of the maxillary teeth anterior to the first permanent molar is taken and it is summed up. Then sum of the mandibular 6, that is from canine to canine, is measured and they are also summed up. And the mandibular incisors are also summed up. Okay, now determination of the overall ratio. According to Bolton, a mean ratio of 91.3 will result in the ideal overjet overbite relationship as well as a posterior occlusion. The overall ratio, that is sum of the mandibular 12 divided by maxillary 12 into 100. So if this ratio is less than 91.3, it indicates a maxillary tooth material excess, and it indicates that the mandibular tooth material excess if it is more than 91.3. An amount of maxillary excess can be calculated using the formula sum of the maxillary 12 minus sum of mandibular 12 into 100 divided by 91.3. And the amount of mandibular excess can be calculated using the formula sum of the mandibular 12 minus sum of maxillary 12 into 100 divided by 91.3. So a similar ratio is computed for the 6 anterior teeth. That is, an anterior ratio of 77.2 will provide an ideal overjet and overbite relationships if the angulation of incisors are correct and if the labellable thickness of the incisal edge is not excessive. If the anterior ratio exceeds 77.2, then there is an mandibular tooth material, excessive mandibular tooth material, and if it is less than 77.2, there is an excess maxillary tooth material. So Bolton's analysis prediction do not take into account the sexual dimorphism in maxillary cuspid widths. Thank you.